Thank you for listening to the National Award-winning PRS Journal Club podcast. I'm happy to present your hosts, Drs. Lily Mundy, Raj Parikh, and Kyle Sanniec.
Hi everyone, and welcome to the May 2019 edition of PRS Journal Club podcast. I'm Lily Mundy, PRS Resident Ambassador from Duke University, and I'm joined by my co-resident ambassadors, Raj Parikh from Washington University in St. Louis and Kyle Sanniec from UT Southwest. The articles that we will discuss can be read for free on prsjournalclub.com, including an archive of all past Journal Club articles. Today we have the honor of being joined by Dr. Terry Myckatyn, Professor of Plastic Surgery and Director of Cosmetic Surgery and Breast Microsurgery at Washington University School of Medicine in St. Louis. Thank you so much, Dr. Myckatyn, for joining us for this PRS Journal Club podcast.
My pleasure. It's great to be here. Thank you.
The article that we will be discussing is Venous Thromboembolism after Abdominal Wall Reconstruction, a prospective analysis and review of the literature, which is from senior author Dr. Jeffrey Janis out of Ohio State. This is a retrospective review of a prospectively collected database of patients who have undergone complex abdominal wall reconstruction by a single surgeon from a 5-year period from 2013 to 2018. The authors collected demographic data, perioperative anticoagulation, Caprini score, OR time, and postoperative venous thromboembolism events. The authors identified 175 patients. The average age was 55, 57% were female, 95% were white, and average BMI was 33. 10% of patients were on antiplatelet therapy pre-op. This was held for the majority of patients and discontinued on discharge from the hospital. 7% were on anticoagulation pre-op, and this was held for all patients pre-op. 98 of patients had an operative time of greater than 4 hours as a combined general and plastic surgery case, and just under 70% of patients underwent a component separation. Preoperative DVT prophylaxis for their patient population was sequential compression devices for all patients and chemoprophylaxis in 29% of patients, with almost all of those patients receiving sub-Q heparin. DVT prophylaxis postoperatively included SCDs and chemoprophylaxis that started 6 to 8 hours after surgery and continuing until discharge. In their group, 54% received sub-Q heparin for this prophylaxis and 45% received enoxaparin, with 2 patients not receiving any chemoprophylaxis for an overnight observation only. 3 patients were discharged with extended chemoprophylaxis for 2 to 3 weeks, which was selected based on attending discretion. Their average length of stay was 7 days, and they used multimodal pain therapy with epidurals and tap blocks with liposomal bupivacaine, and then a variety of different oral medications. They had no postoperative bleeding complications in their group. They did use pretty strict postoperative ambulation guidelines to require patients to ambulate once in the day of surgery and then 5 times daily starting at post-op day 1, continuing through 6 weeks post-op. 2.3% or 4 patients had a postoperative venous thromboembolism event, all of which were PEs that were confirmed by a CT-PE protocol. They had no documented DVTs, but also didn't do any additional clinical screening for subclinical DVTs or PEs. The average day of post-op PE diagnosis was 11 days, and 2 patients had been discharged prior to this diagnosis. Within the group of 4 patients who had a PE in their study, 75% of them had had a previous venous thromboembolism event versus only 8% in the non-PE group. Other than that history of a venous thromboembolism, that group was otherwise similar in medical status to the non-PE group. All patients in the PE group underwent a component separation. 2 had a unilateral transverse abdominis release, 1 had a bilateral transverse abdominis release, and 1 had bilateral external oblique release. In terms of their significance and their findings, they found a significant difference between the average Caprini score of the non-venous thromboembolism group, which was 5.3, versus the venous thromboembolism group at 8.5, and that p-value was 0.0005. Their pre-op Caprini scores were 6, 8, 10, and 10 for their PE group. They did have a trend with a p-value of 0.08 for a difference in their peak inspiratory pressure measurements between the PE group and the non-PE group, going up to 5.5 for the PE group versus 2.6 for the other group. So overall, they reported a venous thromboembolism rate of 2.3% in their group. They additionally performed a literature review and found 3 other studies that looked at VTE rates after abdominal wall repair, excluding those studies that were looking at abdominoplasty patients. All the studies they found utilized the ACS-NSQIP database, and they all stated less than 1% venous thromboembolism rates, with the exception of a subset of obese and morbidly obese patients. So I think there's a couple advantages to the study. They're the first study to look at rates of venous thromboembolism in hernia patients. Despite all of the literature we have in abdominoplasty patients, this looks to be sort of an area that was lacking, and they didn't use the national database, so we have a little bit more clinical data. to think about it. However, it's a single surgeon retrospective review. They didn't have all pieces of clinical data, like they didn't report follow-up time, and there wasn't standardization that they shared for chemoprophylaxis for the extended postoperative patients. It's also unclear what the compliance was for patients in terms of their SCD use and their ambulation protocols. And then lastly, they only picked up the clinically evident VTEs, so their rates of subclinical VTEs have been higher. But I'd like to just start by turning it over to you, Dr. Myckatyn, and seeing what your thoughts were on the article and sort of what your takeaways were.
I thought that the results that they report are pretty consistent with what I would have expected from our experience with abdominal wall reconstruction as well. I do agree with you that one thing that we don't really know is sort of the occult DVT rate in the study, since they were really just reporting those events. I also suspect that the protocol they use is fairly standard amongst other, large academic centers. It's pretty similar to what we would use at our institution at Washington University as well. And I do definitely commend them for looking at their large institutional series. And I would also say that, like with other studies with NSQIP, one of the limitations there is that it is only 30-day data, and as with other large databases, there are certain data fields that are omitted, and you always have to wonder about data abstraction. So I definitely commend them for the study that they performed.
Yeah, I agree. I think it's not really a study that's designed to try to see if these patients should be receiving DVT prophylaxis. Obviously, they all did. And it is sort of consistent with patients who have the Caprini scores 7 to 8 or above 8 and sort of having these higher rates of DVT events or PE events, and it's likely that they did everything that they could for these patients. So I'm not sure that they, and I think this is something the authors sort of talked about, was there's going to be a rate of breakthrough events for PEs or DVTs in these patients, and I'm not sure that we're sort of missing out on an opportunity to sort of optimize their risk.
Yeah, no, I agree with you, and it's not like you're going to prophylactically place a filter in some of these patients with the potential risk that's associated with that. So I agree with you that even with fairly optimal management, unfortunately, there will still be some individuals that sort of slip through the cracks.
Yeah, Raj and Kyle, I'm curious, do you guys have similar protocols in how you're managing hernias post-op in terms of DVT prophylaxis and chemoprophylaxis at your institutions?
This is Raj. Yes, certainly. I think I agree with Dr. Myckatyn. We're at Washington University, and we use the Caprini score for our general reconstructive procedures, including abdominal wall reconstruction, obviously in deep flaps where you're putting mesh into the abdominal wall as well. One of the things that, for me is just interesting with the VTE prophylaxis and anticoagulation is just duration. And I think that's something that is really similar as, the preoperative doses and the doses when you're in the hospital, but I'm not sure that there's an optimal amount of time that's been determined in the literature or on studies on how long we should keep patients anticoagulated. And so that's something that at least personally we struggle with in determining for patients at the time of discharge, how long do you keep them on anticoagulation? It seems in their experience at Ohio State, they're doing, 2 weeks. But there certainly people have made the argument, at least in deep flaps and other kinds of general reconstruction, where there's some level of immobility, and abdominal wall would certainly fit into that you should be anticoagulating people up to a month. So, our colorectal surgeons anticoagulate hemicolectomies and stuff up to a month after surgery, so they get Lovenox daily. I think that's something that really needs to be teased out still, because there certainly is a risk of keeping patients on anticoagulation. So we just have to kind of figure out what the ideal time is.
Yeah, I think you bring a really great point there. We at Duke, a lot of times our surgical oncologists, when they do oncologic resections, those patients are going home on extended DVT prophylaxis. And, the study here mentioned they had 3 patients that did that, although they didn't really state the reason other than attending discretion for those patients. So I wonder if there was some type of oncologic resection at the time of hernia repair in those patients or not. But I agree that I don't think at least we have a protocol for doing that for our hernia patients post-op, if that wasn't being driven by the oncologic or colorectal team.
Yeah, it's Kyle here. At UT, we have the same kind of issue. We know what to do in-house in terms of giving DVT prophylaxis while they're right after surgery. But that question goes back and forth of when do you send patients out with 2 weeks of anticoagulation or a month of anticoagulation, and it's something that we struggle with, and it's kind of just a general gestalt, I guess, of when you know when to do it or not. But that's something that we're still trying to figure out in terms of what's the best thing to do for the patients for their anticoagulation.
Yeah, this is Dr. Myckatyn. I would say that at our institution, the other thing to consider is in these cases where we're really not sure, but we feel like the patient is at high risk, would be to consult the hematology service, frankly, and get other physicians on board to help with your decision-making process.
I think that's a great point. Just out of curiosity, in terms of your post-op protocols for your hernia patients at your institutions, do you all encourage ambulation on post-op day 0 and this much, early on in the post-operative period? Do you all use abdominal binders? I know some people have thought they might contribute to increased rates of venous stasis or venous thromboembolism events. I'm just curious as to what y'all do at your institutions.
At our institution, I think that this would be based somewhat on a case-by-case basis. So, for example, the abdominal, so Raj had mentioned just the abdominal-based free-flap breast reconstructions. We're trying to typically get them into a chair with some early ambulation on day 1. With abdominal wall reconstructions, I do think it depends largely on what other sort of concurrent procedures were performed for them at the same time, if there was a flap involved or other colorectal procedures or resections. And so in those cases, I do think it does somewhat depend on the goals of the other services as well. But certainly if there are no contraindications, that we would move them on day 0 if able to.
Yeah, at UT, we do a lot of early ambulation post-op day 0. We intermittently use binders. Mostly it's at patient discretion. Specifically when they start moving more, it makes them feel a little more comfortable, but we're not dogmatic about it, I don't think, in terms of every patient absolutely has to have a binder and it has to be snug and things like that. So our main goal, again, is just getting them up and moving them as often as possible and using kind of multimodal pain therapies to try to get them up so they can start moving around in addition to just anticoagulation.
Yeah, I think that's all obviously very important for these patients and really can also help decrease their venous thromboembolism events. I think with that, we'll end the discussion of this article. Thank you everyone for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also remember to tune in to the other 2 articles that we'll be discussing in this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we'll be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you have not done so already. It is there where our monthly journal club takes place. And once again, thank you so much, Dr. Myckatyn, for joining us.
My pleasure. Thank you.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.